Welcome. Review of this week, RBC disorders. All about patients with anemia. Note that this is covered already in MB2 HRM. Pathophysiology of anemia and the basic sciences relating to RBC production, hematology. So this week's case, tired woman. A 63-year-old woman presents with a 1-year history. So prolonged, increasing lethargy and more recent onset of dyspnea on exertion, ankle swelling, difficulty walking, increasing lethargy, shortness of breath. That means oxygen is not sufficient. Could be cardiac or could be respiratory. Ankle swelling usually suggests pedal edema. Difficulty walking for last 2 weeks. So it's all pointing towards progressive worsening of weakness, and she also has some unsteadiness to make you think of neurological conditions for final exam. She has taken course of iron tablets, which is the usual treatment when GPs suspect anemia, but note that you have to investigate before giving any specific medication. Palpitations, chest pain on exertion, relieved on rest, suggestive of cardiac ischemia. Ischemias can be due to atherosclerosis, but also due to severe anemia. Fever in a patient with anemia, we think of decreased WBC as well. Loss of appetite and some loss of weight. So something is happening with nutrition. She has been diagnosed with hypothyroidism in her 50s. She is on thyroxine to make you think of hypothyroidism as a cause of anemia, and particularly macrocytic anemia, a differential diagnosis for megaloblastic anemia. And she is on anti-inflammatory drugs. So peptic ulcer, gastritis, chronic blood loss, and iron deficiency anemia. So as usual, in a CPC, we try to put many features suggestive of many differential diagnoses. She's tired all the time. Sleep is normal to exclude psychological causes. She bruises easily. You should also think of bleeding tendency. She is pale, so anemic, and there is mild jaundice, suggestive of hemolytic anemia. But also she has features of severe anemia, that is stomatitis and glossitis. Remember in MB2 HRM, we discussed epithelial disintegrity in case of anemias due to deficiency of either vitamin B12, folate or iron. And there is a family history of Raynaud's disease or other autoimmune disorders which could also give rise to anemias. And also pernicious anemia, autoimmune gastritis, atrophic. Aunt had a stomach cancer. A family history of cancers can also give rise to anemias. Her diet, meat and 2 vegetables to make you think of nutrition as a cause of anemia. And there are many clinical learning. Romberg sign positive, reflexes decreased, Babinski is positive, decreased sensation in the lower limbs to make you think of vitamin B12 neuropathy. So there's a big list of differential diagnoses. Most common cause in an elderly is blood loss, chronic blood loss, giving rise to iron deficiency, either gastrointestinal or genitourinary tract. Megaloblastic anemias are common in the elderly because of poor nutrition or pernicious anemia, a autoimmune disorder. Hypothyroidism and other endocrine causes can also lead to anemias. And hypothyroidism particularly also gives rise to high MCV macrocytic anemias. Malignancy as a cause of anemia in elderly is important. Malignancy can cause bleeding and iron deficiency, suppress the bone marrow, aplastic, hypoplastic anemias, and anti-malignancy therapy reduces folic acid, and that gives rise to megaloblastic anemia. So there are many causes of anemia in a case of malignancy. Aplastic anemia, bone marrow failure, And in this patient, differential diagnosis should also include just the lethargy, weakness, cardiovascular conditions, respiratory conditions, metabolic conditions. Now, the laboratory results showed very low hemoglobin, WBCs are marginally low, and platelets are low. So, this is a case of pancytopenia, decreased RBC, WBC, and platelets. Although not given, but an important investigation is MCV. And if it is megaloblastic, usually it will be more than 120. Little less would be with just reticulocytosis, hemolytic anemias. So macrocytic anemias, that is MCV high, common cause is drugs and liver. Bilirubin and other things are normal, so unlikely liver disease here. But note this, vitamin B12 is markedly low, red cell folate is normal, and the patient was further investigated for parietal cell antibodies and intrinsic factor blocking antibody, a feature typical in pernicious anemias. A high MCV, commonest cause clinically is drugs, antifolate drugs. Alcohol is an important cause of macrocytic anemia and liver disease. High reticulocytes in hemolytic anemia, blood loss anemias can give rise to artificially increased MCV. And megaloblastic anemia is only about 10% in the clinical situation, which is due to B12 or folate deficiency. Read about pernicious anemia, PA, pathogenesis, and complications of vitamin B12 deficiency, neurological, psychological conditions. Nowadays, the new test, holotranscobalamin, HTC, measures better than just the total serum vitamin B12. It's a better indicator of B12 status. Also, celiac disease screen, folate, and even iron studies are checked because combined B12 and iron can occur in pernicious anemia because of atrophic gastritis with lack of acid in the stomach. Previous years we have used different scenarios in the CPC. An aboriginal girl, shortness of breath following exercise. So a feature typical of chronic blood loss, iron deficiency anemia in younger age could be due to menstrual blood loss, worms, or even nutrition. 68-year-old pensioner, husband is a butcher, worm infestations, infections. She's on warfarin, so drug-induced anemias. Hypertension on aldomet therapy known to cause drug-induced hemolytic anemia, as well as yellow meaning jaundice, so suggestive of hemolytic anemia. There are many scenarios in the exam we use, so think about in a child nutrition, worms, in an adult woman menorrhagia, multiple pregnancies, and rarely malnutrition, and again GIT blood loss can be there. Adult man, GIT blood loss and leukemias and other malignancies. Elderly woman, GIT blood loss, colon cancers, endocrine hypothyroidism, and chronic diseases like diabetes, renal failure. Chronic renal failure, anemia of chronic disease, and renal causes of anemias, lack of erythropoietin, and also bleeding in case of chronic renal failure. Just an elderly patient, they will have nutritional deficiency of B12. GI bleeding should be thought of in all the cases. Pathology core learning, anemias, commonest iron deficiency, B12 and folate metabolism, and hemolytic anemia. Minor learning, polycythemia, opposite of anemia, excess hemoglobin, primary and secondary. Anemia of chronic disorders and its mechanism. Briefly, congenital anemias, sickle cell anemia, thalassemia, G6PD deficiency anemia, and spherocytosis. Aplastic and hypoplastic anemias, including bone marrow failure. And very briefly, myelodysplastic syndromes, okay? And online slides, only 3 important. Autoimmune hemolytic anemia as a commonest example of hemolytic anemia. Iron deficiency, megaloblastic anemia, apart from one normal blood smear. Okay, thank you.